Welcome to this module on antiphospholipid syndrome, where you will learn about the basic key points of antiphospholipid syndrome and the autoantibodies used for diagnosis. Antiphospholipid syndrome, also known as APS, sticky blood syndrome, or Hughes syndrome, is a rare autoimmune disorder characterized by recurring blood clots or thromboses. Blood clots can form in any blood vessel of the body. The specific symptoms and severity of APS vary greatly from person to person, depending on the exact location of a blood clot and the organ system affected. APS is characterized by the presence of antiphospholipid antibodies in the body. In APS, antibodies mistakenly attack certain proteins that bind to phospholipids. Phospholipids are found throughout the body. The reason these antibodies attack these proteins and the process by which they cause blood clots to form is not known. The characteristic antibodies in APS are detected with an anticardiolipin assay and/or anti-beta-2 glycoprotein 1, or the sample is lupus anticoagulant positive. There are no clinical practice guidelines covering all aspects of the diagnosis and treatment of APS. The available guidance is the classification criteria from 2006. The criteria for APS requires the identification of at least one clinical and one laboratory criterion. The laboratory criteria includes a positive result for lupus anticoagulant and/or anticardiolipin and/or anti-beta-2 glycoprotein 1. All results need to be confirmed with a positive result after 12 weeks. Being positive for one or several of these markers means that patients are at increased risk of thrombotic events. The risk of thrombosis in patients with APS is estimated to range from 0.5% to 30%. The specific symptoms associated with antiphospholipid syndrome are related to the presence and location of blood clots. Blood clots can form in any blood vessel of the body. Clots are twice as likely to form in vessels that carry blood to the heart, called the veins, than vessels that carry blood away from the heart, the arteries. Any organ system of the body can be affected. The lower limbs, lungs, and brain are affected most often. APS also causes significant complications during pregnancy. Recurrent miscarriage occurs in about 1% of the general population attempting to have children, with about 10 to 15% of these women being diagnosed with APS. APS is more common in women than men in a ratio of 5 to 1. Although the mean onset of clinical manifestations tends to occur in the middle age range, it may manifest in children and older patients as well. The most common vascular manifestations of APS are deep venous thrombosis of lower limbs, pulmonary embolism, and cerebral ischemic attack. Early and late miscarriages are the major features of obstetric APS. Catastrophic APS occurs in fewer than 1% of APS patients and is characterized by multiple small vessel thrombotic events leading to multiple organ failure and substantial morbidity and mortality. The syndrome is generally of acute onset and defined by the involvement of at least 3 different organ systems over a period of days or weeks. Other manifestations of APS include thrombocytopenia, which means a low number of blood platelets, heart valve disease, including valve thickening and leakage, nephropathy, livedo reticularis, which is a lace-like purplish discoloration of the skin, and skin ulcers. Although these manifestations are relatively common features of APS, they are not included in the classification criteria because of their low specificity, which means that the manifestations are not unique to APS. In addition, a wide range of non-criteria neurological manifestations have been associated with APS. These neurological manifestations include untreatable headache and migraine, epilepsy, chorea, with involuntary, irregular, unpredictable muscle movements, ocular manifestations, and retinal vessel thrombosis. The presence of IgA antibodies against cardiolipin and beta-2 glycoprotein 1 are not included in the criteria either, but known to be associated with APS. One of the main risk factors for APS is the presence of other autoimmune conditions. For example, 30 to 40% of patients with systemic lupus erythematosus, approximately 42% of patients with Sjögren's syndrome, and approximately 33% of patients with rheumatoid arthritis will also have APS. A clinical syndrome resembling multiple sclerosis has also been described in APS, raising the issue of a correct differential diagnosis. Patients who should be screened for antiphospholipid antibodies include patients with unprovoked proximal deep vein thrombosis or pulmonary embolism after stopping anticoagulation for at least 7 days, young adults, such as those aged under 50, with ischemic stroke, and women with recurrent pregnancy loss, defined as more than 3 pregnancy losses before 10 weeks gestation. Patients should be tested for lupus anticoagulant, which is a coagulation assay that detects subsets of anti-beta-2 glycoprotein 1 antibodies and anti-prothrombin antibodies. IgG/IgM anticardiolipin, which, despite the name, detect mainly antibodies to beta-2 glycoprotein 1, and IgG/IgM anti-beta-2 glycoprotein 1. The difference between anticardiolipin and anti-beta-2 glycoprotein 1 is that anticardiolipin also includes phospholipids in the coated well, in addition to beta-2 glycoprotein 1. Both tests are still included in the classification criteria due to lack of evidence that anti-beta-2 glycoprotein 1 can yet be considered a substitute for anticardiolipin. Due to the low clinical specificity of these tests, they should also be interpreted in the context of each other and the clinical history. Lupus anticoagulant is the most predictive test for thrombosis. The presence of anticardiolipin or anti-beta-2 glycoprotein 1 in lupus anticoagulant positive patients increases specificity. Positive tests should be repeated because antiphospholipid antibodies can be present in short intervals due to other reasons such as infection or drug use. APS patients can be divided into different categories. The first includes patients with more than one positive test in any combination. The second, if only lupus anticoagulant is positive. Third, if anticardiolipin is positive. Or fourth, if anti-beta-2 glycoprotein 1 is positive. Triple positivity is the most predictive profile for clinical manifestations and recurrences despite conventional treatment. Patients carrying both anticardiolipin and anti-beta-2 glycoprotein 1 isotypes are at higher risk of developing clinical events. A lot of patients with suspected APS will be receiving treatment for their symptoms. However, it is essential to confirm their symptoms are caused by APS rather than another thrombotic disorder. Furthermore, by testing and categorizing the patient into the categories just described, it is possible to assess the patient's risk using these tests. In conclusion, detailed clinical and laboratory assessments are very important to provide a full picture of APS. Using lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1, you can confirm a diagnosis of APS and identify patients at higher risk of recurrence or developing clinical events. A detailed clinical and laboratory assessment can provide the patients with appropriate treatment dependent on their risk profile earlier in their disease journey, and by this potentially improve their quality of life. Why is it crucial to diagnose APS at an early stage? Antiphospholipid syndrome is an acquired autoimmune condition that affects young patients, primarily women, in the most productive years of their lives. Organ or tissue damage can result in disability, job loss, limitations in activities of daily living, cognitive dysfunction and fatigue, and recurrent fetal loss. APS is underrecognized and underdiagnosed and can have devastating results if untreated, mainly due to uncontrolled thrombosis. Treatment can reduce mortality and morbidity in young people, who often present with stroke, myocardial infarction, and deep vein thrombosis. There are no clinical practice guidelines covering all aspects of the diagnosis and treatment of APS. The available guidance is the classification criteria that are primarily intended for clinical research. The classification criteria for APS require the identification of at least one clinical and one laboratory criterion. With no formal clinical guidelines in place, diagnosis and treatment of APS is largely based on consensus and expert opinion. The key take-home messages for APS are that antiphospholipid syndrome is a rare autoimmune disorder characterized by recurring blood clots known as thromboses. APS is characterized by the presence of antiphospholipid antibodies in the body. The characteristic antibodies in APS are directed against cardiolipin and/or beta-2 glycoprotein 1, or the sample is lupus anticoagulant positive. This means that patients are at increased risk of thrombotic events. APS is underrecognized and underdiagnosed and can have devastating results if untreated. It is therefore crucial to have excellent laboratory tests to support the important diagnosis of APS. Thank you for your attention.